Our participants in? Okay, hello. Hi everyone, this is the Center for Management and of Healthcare Services, perhaps the year-ending seminar, virtual seminar. Today we have Professor Namrata Chindarkar, who is an associate professor at the JSW School of Public Policy, Indian Institute of Management, Ahmedabad. She is also a fellow of the Initiative for Sustainable Energy Policy at the Johns Hopkins School of Advanced International Studies, and was previously a faculty member at the LKY School of Public Policy in NUS Singapore. Today, she's going to talk about malnutrition and what she's observing in her research in children in China. Namrata, over to you.
Thank you, Chirantan. Thank you for the introduction, and thank you so much for inviting me to present on this forum. So we'll get started right away. I'll start my screen share. Okay. So what I'm presenting today is work which is joined with Maki Nakajima and Alfred Wu, both of them at the National University of Singapore. And they have also very kindly made time and are joining us today. So as and when if I need them to pitch in, I will call upon them. So what we are working on here is to look at inequality of opportunity in health. And I will elaborate further what exactly is this framework that we are looking at is. And in particular, we are looking at China. Of course, this was driven partly by data, the kind of data that comes from China, but also because China has a very unique setup when it comes to movement of people within the country. And that makes it an interesting case when it comes to looking at any rural and urban differences, but also increasingly differences among its migrant population. So as has been recorded now by several studies, although China has recorded impressive economic growth, there is also an increase in income inequality. And some recent estimates, they say that about 38% of the rural-urban differences in income inequality can be attributed to that which is coming from the rural-urban differences. So overall income inequality, and about 34% of that comes from the rural-urban differences. There is a lot of discussion around income inequality in China, and that has been the case for several years, a lot of literature on that as well. However, when it comes to health inequality, a lot less attention has been given to that. There is enough evidence again to suggest that life expectancy has considerably increased, and we all know, that comes with better incomes, that comes with better public services. So all of that has definitely happened. However, if we look at, that is the average picture. But once we start to slice and dice the data, the differences between urban and rural areas, they still continue to persist. And that is what we really want to look at, which is health inequality between the different populations within China. And so far, the missing piece has been the rural-urban migrants. There was this very important work which was published in 2010 by White, and that led to a lot of controversial discussions when he argued that China is now a country of three peoples. It's not only rural and urban, but now there are these migrant residents, many of them who have no formal residence status in their destination cities, which is what makes them very unique, because there are lots of services from which they are systematically excluded. And then he makes this argument about how this is, in terms of social unrest and so on, this is not a very positive trend, and which is why I said it was a slightly controversial argument to make. What is known now, again, this is something which has been in place in China for a very long time. In fact, from when there was the imperial structure, what's called the hukou system, which is the household registration system. And that is argued to have deepened the rural-urban differences. And again, lots of studies on this structural factor. So what we are out to examine is when we look at migrants, and particularly in the context of health as an outcome, are they more disadvantaged when we compare them with the rural and their urban counterparts? And we will discuss more in detail in terms of what is the specific sample that we are looking at. Again, very briefly, what literature points to when it comes to health inequality in China is, of course, as I said, the hookah system. There is something which is quite unique to the system because it remains one of the few formally implemented systems in a country as the size of China. And of course, that also is the reason why they started controlling people's movements. All the reforms which started way back in the 1970s. So you even today you will find families where some of the members will have urban hookahs, but the others who will not have urban hookahs. And there were some reforms in 1998. So historically, what was happening is that the children, they would inherit it from the mother, but then that was changed, and you could either get the mother's or the father's hookah. So within the same family, you could have people with different hookah, and which means they would have access to different access to public services, and that in terms of that structure of the system, that still remains. Although there have been a lot of reforms to counter the negative effects that the system has resulted in, and we will talk about them in a little bit as well. But as I said, the system is still in place. The other is with the reforms, the economic reforms that were implemented, there was an urban bias, and that meant that the city centers obviously attracted more resources. They had better public services, and that also resulted in inequalities when it came to people's access to those services. So obviously, if you had you were always an urban resident and therefore you got access to better services, then your outcomes in terms of income, education, health, all of them were always better than your rural counterparts, for instance. Now, equality of what? Now, this was a question which was raised by, famously by Amartya Sen in one of his Tanner lectures. And that is really what we want to focus on. So we are applying a different framework to understand health inequality in China. So while a lot of the literature looks at, there are, so there is a question here similar to the ration card. It's not. It's quite different from that. It is really more formalized, which actually prevents where people can stay and what kind of services they can access. In India, there is no such restriction. So even if you have a ration card somewhere else, you can always get it transferred. And people can move in and out of the ration card and so on. But the hookah system is a little more rigid than that. So in terms of what has been done so far when it comes to health inequality in China, a lot of studies, they rely on measures such as the income-related health inequality. That is very similar to the Gini coefficients. It's a concentration index, essentially. So you just plot the cumulative population by income, and then you plot the cumulative proportion by different levels of health, and then you see what the extent of health inequality is. So those are the kind of measures which have been typically used. However, what we argue is not just in the context of China, but anywhere else, whenever you use such measures, what they do not tell us is whether health inequality is a result of lack of effort, or is it because of circumstances? And I will elaborate on these two terms a little more when we come to the theoretical framework. So effort and circumstances are going to be two important terms as we go forward. But essentially, to clarify at this point, circumstance is anything over which the individuals do not have control. So your gender, your race, your region of birth. So that is something which is beyond an individual's control, and that should not be a reason why people are discriminated against. So that is the basic premise of equality. that we are going to be using. And we situate our work within this normative framework, which is the inequality of opportunity framework, and we apply it to health inequality. So this work draws on the frameworks which have been proposed by Rawls, where he talked about the whale of ignorance, right? So imagine you, and think of yourself as a policymaker. So what you should not be doing is to provide different services to your citizens based on their circumstances, where they live, what their gender is, and so on. You should be behind a veil of ignorance such that everyone receives the same level of access to services. And this was further developed by scholars such as Dworkin and Amartya Sen. Now, more recently, this work has been formalized and brought into the mainstream philosophy and public affairs discussion by John Romer. And he proposes this inequality of opportunity framework and tries to provide us at least some way of being able to operationalize it. So while the normative frameworks usually make a lot of sense, the challenge really is how do we translate all of that into empirical work? So the inequality of opportunity framework is one such starting point. And Romer identifies 5 words in the vocabulary of this framework. So there is circumstance, there is effort, there is type, there is objective, and there is an instrument. If we have to look at it formally, this is a very simple representation of Romer's framework. So if you look at an individual, whatever might be the outcome that the individual is trying to maximize. So just a very simple production function for the individual. Now, if the objective here is to maximize an individual's health, then it has to be a function of the effort, and that individual will belong to a certain type. Now, type is a combination based on circumstances. For instance, a type is an urban resident, a rural resident, a migrant resident, and the circumstance here would be your place of birth or your region of birth. It could also be a combination of different circumstances. So it could be your region of birth as well as, say, your gender. So a rural female, and a rural male, and so on. So that is a type. And so essentially what this says is that the outcome that any individual achieves will be a combination or will be a function of effort, the circumstances that the individual's type belongs to, and also any policy interventions which are targeted towards that particular type. So, that's sort of the a very simple explanation of the framework. And what Romer argues, the general goal seems to be fairness and equality, but the Romer setup is about productive efficiency. Is that consistent? Well, it is still about equality and fairness. So it is not only about productive efficiency. You can think of it that way. So I would say, in terms of the kind of outcomes that even Romer would be interested in, would be, say, education achievement, health status, or any other objective measure of health, and looking at the distributions based on this function. So it is not just about productive efficiency, but also overall how the distributions seem to sort of come out once you fix a type and look at the outcomes, plotting, say, the CDFs. So that is something that we will be doing as well. So the goal is still equality here, although it's represented as just as a very simple production function here. So is there any previous work done in this space? So there are some studies, many of them coming from developed countries, and what they have identified as circumstances which affect health and which result in either equality or inequality of opportunity in health is parents' socioeconomic status. What kind of family do you belong to? Is it a high income or a low income family? Parental health, that's the endowment effect. What is the kind of endowment that you get in terms of health from your parents? However, I would say, and that's the argument that we make as well, largely there is still a gap in terms of understanding inequality of opportunity in health, in the sense also because there are so many different ways in terms of looking at circumstances and so many different ways of defining a type. What is that group and what do you want to compare that group with? What are the different types that you want to compare? So there is still a lot that can be done in terms of understanding inequality of opportunity in health. So here in our paper, in terms of contributions, this is, to our knowledge, the first paper that looks at inequality of opportunity in health in the Chinese context. Also the first one that explicitly brings in rural-urban migrants in the context of health that is not yet there in the literature on China. And we also try to throw some light on why these inequalities or equalities would persist or not persist, depending on the policies that have been implemented during the time frame that we are looking at. As I was explaining before, a big challenge that remains in translating these normative frameworks is always operationalization. How do we identify the circumstances, and how do we identify the types that you want to look at? Drawing upon literature and mainly the context that we are studying, our main circumstance of interest is the resident status, which is the hukou status. I'm just going to look at the question. Oops, what happened to my chat window?
I was just saying there's an old Lancet in 2008 which talks about internal migration and health in China. So, and it has a lot of citations as well. So you may want to engage around it. That's all.
Sure. Yeah. Okay, I don't know why sometimes I can't see the chat window. Thank you, Chirantan. Thank you for that. So yes, there is literature, but as there could be different ways of thinking about inequality, particularly health inequality in our case, and what we bring in, we argue, is this framework in particular. So the circumstance that we look at is the hukou status, and then drawing upon the other literature, we look at parental health. In terms of the specific measures that we are using, one of them is the D index, the dissimilarity index, and that you can compute by controlling for a range of other covariates. So we include a lot of other covariates as well, which are also circumstances. Gender, the province, which is equivalent of a state in India, for instance, the minority status, number of children in the household, household consumption expenditure, parental education, and whether both parents are present. So I will come to the data in a little bit and explain why we are looking at these particular covariates. The objective or the outcome that is of interest to us is the self. In this case, it's the parent assessed health status, because we're looking at a sample of children. And while we would have liked to use more objective measures, the survey that we are using, which is the China Household Income Project, for some reason, the questions that they ask are not consistent across waves. So in one of them, they ask some really nice questions on the children's physical health. And in the next round, those questions are not asked. But we wanted to do this over time comparison. So if you wanted to just a cross section, of course, we could have used them, but we wanted to do this over time comparison based on a lot of reviewers' feedback that we received. So this is one question that was consistently asked. And then based on the two circumstances, we classify the entire sample into 6 types, which is a combination of the hukou status, urban, rural, migrant, and the parental status or health status that we classify as either high or low. And this follows what Romer sets out as conditions that should satisfy the type, which is that the chosen circumstances should have a direct or an indirect effect on the objective or the outcome. And then the circumstances, of course, should be beyond the individual's control. Hookah, of course, by its very nature, is not within the individual's control here. And we look at children. So for them, the parental health status is also exogenous. So that is also something which is not in the control of the children. So we are using this particular survey, which is the China Household Income Project, the two rounds, 2002 and 2013. So a lot of, as we were working on this and based on the feedback that we received, the idea that constantly emerged is that the health landscape in China is changing so much that you cannot really look at things just using one slice of data. So it will be nice to look at changes over time, which is why we're looking at 2002 and 2013, and then seeing how these patterns of health inequality are changing. So again, to repeat, it's a sample of children, newborns to 16 years across the urban, rural, and migrant households. We have a total of about 21,452 observations across the two waves of data. The two methodologies that we use to examine inequality of opportunity in health, first is the dissimilarity index or the D index, and then we also decompose it using the Shapley decomposition. And we also run some stochastic dominance tests, which is becoming more and more prevalent, especially in the inequality of opportunity literature. So we use just very simple non-parametric test to look at the stochastic dominance of the different distributions. And I will show you all of those graphs. And to make sure, because the survey was conducted in a way that the urban sample was actually undersampled. To make sure that it's representative, we weight it using the mini census population proportions. For the D index, there is a very, now it's becoming quite popular, and you can see it a lot in the literature as well. So it was first proposed by Burroughs et al., and this was based on the work of John Roma, and they developed this D index to address the challenge of empirically measuring inequality of opportunity. And the work that became very popular was this report that they published on Latin America, and since then it has been applied to many different contexts. And we essentially just follow their methodology. And what the D index measures is the dissimilarity in access for a given opportunity for the types. And what it compares is how much is the difference between the access for that type compared to the average access to whatever is the service that you're interested in for the entire population. So I will not go into a lot of detail in terms of the math, but I'm just going to highlight this part here, this last part here, which is really the difference that the D index is trying to compute. So the access, which is for that particular type, and compared to what's the average access for the entire population. And that is what it is comparing. From the D index, you can compute what's called the human opportunity index. And it's the product of the average access and the 1 minus the dissimilarity index. So the idea being that it looks at how equitably the opportunity is distributed across the population. The interpretation of these two are the closer to zero, the better, because you want the difference to be as low as possible. For the human opportunity index, because of the way it is computed, the higher HOI means that it's a more desirable distribution. So all of these, they have the underlying statistical properties, which are, in terms of what you would think of, any kind of a distribution. So they are Pareto efficient, and then if you have a balanced increase, then obviously it's not going to make any change to the index. So all of those properties apply to the D index as well. The stochastic dominance, fairly straightforward. We're looking at the cumulative distribution functions. And again, I will just highlight this part here, which is we are comparing the distribution functions for a particular type, and then we plot the distribution functions for all types, and then just compare which of them is a better distribution, which is what the stochastic dominance test enables us to do. To clarify our sample, we use a sample of children. Now, one thing, having explained the methodology, one comment which usually comes up is that, well, for individuals, if you're looking at any kind of access, there is an issue of endogeneity. Right? So if, for me, for instance, if I lack access to healthcare, for someone like myself, there's a lot of endogeneity in it because it may depend on my effort. If I just don't have enough income, then I will not be able to access better healthcare. But because we are looking at the sample of children, and everything for them is exogenous. So the circumstances that we use, parental health and hukou, they are exogenous, as well as the other covariates that we use, they are also exogenous. So that addresses this problem of endogeneity, which is usually a comment that comes up when we look at such analysis. So because of our sample and also the way the D-index is conceptualized by Barrow et al. Themselves, they also only look at the sample of children in their analysis. We need not be worried about this endogeneity concern. So continuing with the results now. So there is a lot on this table, but I'm just going to highlight some of the results, the worthy results here. So what we do is we compare between the subgroups, which are urban, rural, migrant, as the entire samples. And then we compare within and between the types as well. So if you look at just the overall subgroups, the urban versus migrant, rural versus migrant, especially for urban versus migrant, you will see that there is a significant reduction in the D index, almost half, like compared to 2002, 2013, the D index is half. If you go back and recall, a D index closer to 0 is better. That means the differences are actually reducing. For rural and migrant, the differences actually increased, and we have some conjectures around why this might be happening. And discussions with my co-author, who's also joined us today, they seem to reveal that it's really a shift in the nature of. So it's not that suddenly the migrant population seems to have just become worse off, but also because there still is a lot of movement happening between rural and urban areas, and it may really be like a population shift. The rural population that is going to urban areas, and that is what is making this trend to become worse off. When we compare within subgroups, again, just within the within the urban population, the differences are reducing, whether they have high or whether they have low parental health. The differences between rural population are increases, again, for similar reasons that I was just describing. But most interestingly, I think, is this between types, because these within and between subgroup comparisons don't tell us what the combination of circumstances. Really the question of interest to us is this, which is the comparison between types. So when we look at that, just looking at the health inequalities between low parental health and the urban migrant and rural migrant. So the ones with low parental health and the different hukou status, that combination is what stands out. The high parental health status differences are not that stark. It's really the low parental health status and a combination of hukou, which is what seems to be driving the inequalities. So some of the differences have gone down. Okay, so the question is, what are the differences in health service that urban, rural, and migrants have access to? So to briefly, describe some of them, if you have an urban hukou, so just think of a city like Shanghai. So if you have an urban hukou, then you will have access to all the public health facilities in that city. If you are in a rural area, of course, the overall standard of the health services will be different. But imagine if you're a migrant worker who is working in Shanghai. For you to be able to access the same level of health services in Shanghai, there would be a lot of barriers. One, maybe you would have to pay up a very high premium for an insurance policy to be able to access the same level of health services. In some cases, they may tell you, you know what, you won't even have access to the health services here. You will have to go back to wherever the rural area that you have moved from and go and access the health services over there. So there are these structural barriers which continue to exist. But as I said, there are some policies which have been introduced, but then there are questions around how those are implemented as well. And in you know in and what also is very unique about the Chinese context is lot not lot all, in fact, the health expenditure, like in India, is a provincial matter, right? So like in India, it is a state subject. In China, it is the provinces that decide how much to spend on the health infrastructure in their own provinces. Everyone is given a budget and they are trying to work with that budget, and everyone has a fiscal capacity, and based on that they will decide. So obviously the priority always goes to the people who have hookah of that particular local government, and then the next in line would be given priority if at all the budget permits. So the differences really come from those kinds of things. Is health inequality or inequality in outcomes? Okay, so I think that is really the question here. So here we are looking at inequality of opportunity because we are looking at the differences based on the circumstance, right? So overall, of course, you are still looking at some kind of an outcome, but the framework or the way of thinking about it is different in the sense that what is the source of the inequality, of the resulting inequality? So instead of looking at factors such as income differences, for instance, we are looking at factors which are circumstances, which are beyond the individual's control, and that is where the difference lies between thinking of it in terms of inequality of opportunity versus thinking of it just in terms of pure outcomes. So that's the normative difference in understanding what we are looking at. So hopefully that clarifies. If not, we will come back to this because that's a very, very important question. Why is it different? Why is this analysis different from, say, the income related health inequality? Our argument is that when you look at income itself is effort, and effort is not something to be particularly worried about if you're looking at it in terms of opportunities. For equalizing access, you look at the circumstances, and then you think of whether the outcomes are equalized or not. Are the health outcomes of all seven better than? Well, I won't say they are 7.66 times better than. So it's just the difference in the average access rate. So what is the average access rate, and what is the difference between the access rate for the urban and the migrant subgroups? That is the way to think of it. So it lies between 0 to 1. So you can think of, or 0 to 100, and you can think of it in terms of a rate. So just 7.66% is the percentage points is the difference in the rate of access between these two groups. That would be the way to interpret these numbers. So overall, the picture that emerges from the dissimilarity index is that the group which is worse off is the low parental status group, and even within that, it's the low parental status and the migrant group, which seems to be not doing that well. And why we say the migrant group is the line L here, which shows the comparison between low parental health urban and low parental health migrant, and that difference has really increased over time. So the migrant population, when you compare it to the urban counterparts, and particularly within the low parental health status group, that is the group that is worse off. I'm not going to again go into the math, but what we are trying to do is let's look at each of those factors which has gone into the in the computation of the D index, and what is it that is contributing the most. Obviously, the two circumstances of interest to us are parental health and HUCAO, and we control for other covariates as well. Parental health status is by far what contributes most to the dissimilarities or the inequality of opportunity here. HUCAO status, interestingly, over time, the influence of HUCAO has reduced drastically. But what does not seem to have reduced a lot, to some extent, yes, but when it comes to the province, the influence of which province you are in. So it does not matter whether you are a rural or an urban resident, but if you are in a particular province, within that province, based on how the local governments function and how the fiscal arrangement is within that province, may still decide the differences in access to health and therefore the outcome of interest. So that still seems to matter a lot. So from this, the conclusion we draw is that the influence of HUCAO status is probably overemphasized, when in fact it has not mattered so much in recent years. In recent years, HUCAO itself does not seem to matter a whole lot. What matters is how is the access given to these people at the very local level, and that may depend a lot on what kind of schemes are implemented in that province, what kind of access to insurance they have. So a lot of the migrant workers still continue to work in not the informal work like you would think of in the Indian context, but still informal in the sense that they would not have benefits package. And if they don't have that, then that limits their access. So technically, they have, they do have an insurance, but the premiums are very high. If their employers refuse to pay those premiums, then they lack access. So there are still these problems at the provincial and the local government level, which need to be resolved and which seem to be the source of these inequalities. So this is the second set of analysis that we are doing, just looking at the distributions. Now, just looking at them, it's not very obvious because you can't identify a first order stochastic dominance just by looking at this. So we're looking at both the 2002 and 2013 cumulative distribution functions here for the 6 types. And this is the stochastic dominance test. Again, what emerges is that parental health, that is really what determines a lot of the distribution, the differences in the distributions. And the last 2 lines which have been highlighted, the differences between urban and migrant within the low parental health status. That also, while there were fewer differences in recent years, the differences seem to have increased. So that message again comes from the stochastic dominance test as well. Okay, so these are broadly the results.
Namrata, there are some questions on the chat window. I want to take that.
I think I have addressed most of them. I was looking at those questions because I have cleared my chat window here. Hold on.
Oh, okay.
Unless
So I'll
it's
read them out.
okay.
So Arpita is asking, what are the differences? Maybe this is a little while back and you have clarified it. What are the differences in health services that urban, rural
Yeah,
migrants have access to?
I answered that, yes. So that I answered as well.
And she later
So
asked about how to interpret the absolute values of the
right, that
numbers.
also, yeah, that also I tried to clarify. The way to the way to interpret would be just what is the difference in the rates of
Hmm.
access between the two groups. So sorry, maybe I did not refer to the particular names of the people who are asking these questions. My apologies, but
No, no, that's fine. Yeah.
yeah, okay, yeah.
And Suresh's question is also answered, is it?
Yeah, so that also I said, what is it that makes this inequality of opportunity rather than inequality in outcomes? Right? So that is the very framework. What is it that you're using as the basis of inequality? Is it the effort or is it the circumstance? And if you're looking at the circumstances, then that is where the framework differs from looking simply at differences in outcomes here. You still need to have something to judge the difference in outcomes, but the basis on which you are deciding whether it is effort or circumstance, that is what makes all the difference when you look at it as inequality of opportunity in health. So hopefully that clarifies. But I will, I'm more than happy to come back to this question because it is it is a different framework, and we're looking at it in a slightly different way than what is traditionally done, looking at just the concentration indices and so on. So very quickly to summarize, we find two important things are revealed from our analyses. One is that seems like this whole thing about hookah status, at least in the recent years, is a little overemphasized. So we don't find that. Okay, so yes, while it is still in place, and it is still very much a formal structural barrier, if you were to think of it that way, the influence of hookah status by itself is not that prominent in our analysis. However, what we may be observing is an indirect influence of hookah, which is what is happening at the provincial levels. And how exactly is the access provided, say, within the same province, but to different residents. So if you look at the same, if you look at Zhejiang, for instance, and someone who is in Hangzhou versus the rest of the province. So simply this first paper analyzing 2002 and 2003 chip data. So this is a question by SP Gore. Well, what we are saying is that it's the framework. So we are not saying it's the first paper using this data, but it's the first paper using this particular framework. And definitely the first paper looking at it in terms of inequality of opportunity in health. So that is where our contribution is. This data has been there for a while. There is also, there is more updated data which we also try to look at, but not consistent. And also some of the very important variables like income and so on, the people who manage the data, they never release those. So whatever is available to us, and based on that, the analysis that we are doing very specifically, to repeat very specifically, the inequality of opportunity framework that we apply is the first time that is being done using this particular data. So hopefully that clarifies. We are obviously not claiming that this data has never been used. It's in the public domain for a very, very long time. There are entire books written based on this data set. So what again, to highlight, the second thing that we observe is that parental health status matters, and this is what we argue might be a consequence of this indirect effect, which is mostly about local governments and the way they are functioning. If parental health is the main determinant, to imply the problem in some sense, it would be future work to examine the determinants of parental health. Could hookah be driving parental health? And thereby, absolutely, Arpita. That is precisely what we argue when we discuss our findings, that when we say parental health, that in itself might be an indirect consequence of the hookah. So because of the hookah, the parents' access is limited. And so therefore, while just the direct impact of hookah may not be there, but parental health access is determined in ways beyond just their hookah. So with the recent reforms, and every province has its own set of reforms. So it's not one countrywide reform, but every province has set up schemes where migrant workers coming to, so as I was saying, think of like Zhejiang, for instance, and say someone who comes from rural parts of the province into a bigger city like Hangzhou, they will have access to healthcare. But what kind of healthcare? And what is the cost of that access? All of those things are not discussed which need to be discussed. So while there are these insurance schemes in place, the premiums tend to be very high, or it is the employers who need to pay the premiums for the migrant workers, and they may cut costs and not really, even though they are entitled to that scheme, they may not sign up their migrant workers for those schemes because it's just costing them too much, and their entire idea is to keep costs low. So all of these things are happening. So it is still the parental access to health. So the parental access to health, definitely what the determinants of that are, one of them would be hookah, but it could be this whole range of things as to what is happening at the local level. And yes, in future work, we would like to do this empirically, but in this paper itself, in the discussion of the paper, we bring in a lot of these, policies and whether they really are implemented in the way they are meant to be implemented or not. And we find that that may not necessarily be the case. So I've just listed some of them here. So there is the urban employee basic medical insurance, urban resident basic medical insurance, the new rural cooperative medical scheme. So I'll just tell you very briefly what these are. So the urban employee basic medical insurance is if you're actively employed, if you're a migrant worker actively employed in a city, you can get access to this insurance. Urban resident means you could be a dependent or you could even be unemployed for some time. You could be a child and you will get coverage under this scheme. New rural cooperative is if you are a rural resident, you have some insurance scheme over there, and then that gives you some access, of course, in the rural areas, but some access also in the urban areas. But from the literature that we have looked at, as I was saying, sometimes the employers just refuse to pay the premiums, or they will say, "Fine, we will sign you up, but for like a very low cost scheme." Some of the schemes, say for under the new rural cooperative medical scheme, it's not very easily portable from your rural insurance scheme, bringing it to under the urban insurance scheme. That portability is very limited, or it costs a lot. So there are these barriers which continue to exist, which means that parents' access to insurance may be limited, which essentially is translating into inequality of opportunity in health for their children. There is this other thing which is also happening, which is that the local governments are responsible for providing health services within each province and even at the sub-provincial level. It's a highly, highly decentralized country. For whoever thinks China is very centralized, that's not the case. It's an extremely decentralized country when it comes to administration. And the local governments, everyone competes for budgets, and the fiscal capacities are sort of predetermined, and they have to function within that. And that also creates barriers in terms of who is then prioritized when it comes to providing health services. And just sort of throwing it out there, what are the policy implications? So the first one, of course, is something which needs to be done. So there are these insurance schemes, but seems like the integration of these schemes with the schemes which the migrant workers may have back in their rural homes, that integration is not there. If that could be made better, so that is something which is a problem which is it could be resolved. And we very briefly in our paper bring up this case of Shenzhen, which is called the Silicon Valley of China. So it has this local government which is very rich and it can afford to spend a lot on public health. But still, there was a study which was published and looked at the difference in per capita health expenditure of the residents versus migrants, and there was a huge difference, almost like half. So when that kind of thing happens in a very rich local government like Shenzhen, then you can only imagine the other local governments. And the second implication is really, it's more ideal. Whether there would be this movement towards dismantling structural barriers altogether. Now, there is absolutely no discussion around that, in the sense that no one says that, oh, we have completely gotten rid of the household registration system. That may not happen. However, there are reforms which are implemented to address some of the negative consequences. So that is done, but a gradual movement where, so one of the reforms, for instance, which happened back in '98 was, instead of just your mother, you could also now inherit your hookah from your father. That was a big change, because otherwise there were a lot of these women rural women who would marry husbands in urban areas, but their children would remain rural residents. But that's not the case anymore. So some of these reforms have been implemented, and there are lots more in each area, health and education and labor markets and so on. But a gradual movement towards completely dismantling the structural barriers would be ideal. That's what we are implying. So with that, I conclude the presentation and then welcome more questions that you may have. Thank you.
So others if you can put up your hands or put it on the Q&A and chat window. We have about 10 more minutes for questions, 7 more minutes for questions. Somebody has a raised hand. Vanita, you want to ask your question? Let's see if you can.
Yeah.
Minnie, can we give her speaking status? Yeah, okay.
Hello.
Yeah,
Yes.
Vanita,
Yeah, hello, ma'am. So I don't have a question. So it's for my own understanding, because I am also working on inequality in healthcare in Indian context. So I have used. So I was just trying to understand that how your method is different or what additional it is adding. If I'm not just using inequality, rather I'm measuring inequity by taking care of the need factors. So let's say I'm looking at inequality in health service utilization.
Right.
So in that case, to measure inequity, I'm subtracting the need, which is based on literature. I've identified that age, gender, and presence of disease is a factor which will determine whether the person will use it or not.
Okay.
Depending on
Okay.
the utilization framework, I have subtracted that particular concentration from my index of the inequality.
Okay.
There I have also taken care of the need, but in case that you are mentioning in terms of opportunity, so I was trying to understand that how you have taken care of whether the person was in need to uh, use or take up that service or not, because maybe that the need itself was lower in urban versus rural.
Okay, okay, fair enough. I guess we have not really looked at it in the way that you have for utilization, because for utilization, obviously, you need to look at whether people actually need the service or not.
Right.
Here, it is still about access in terms of whether what is the based on the circumstances, what would be the average access that they have to health. That would still be sort of the broad question that we would be interested in. The outcome is also different in the sense that we are looking at the health status. We're not looking at actual utilization. That would be nice. And I was mentioning at the very beginning of the talk that we would have liked more objective measures. Unfortunately, the surveys don't ask these questions consistently. So the need itself does not directly feature in our framework. It may feature indirectly because we are looking at a sample of children, right? So as such, you can say that all of them will need access to health. But I think that's the main difference between what we're looking at.
Okay.
Sorry, and then I think there was something about how is it different from your analysis? So was that also a question?
Yeah.
So I think the difference really is in conceptualization. Empirically, I think eventually everything comes down to identifying these factors such as circumstances and so on. So the empirical exercise may be very similar, but it's the framework. How exactly are we thinking of it? So think of it this way. Um, when you're looking at income-related health inequality, the outcome is still some health outcome. It could be self-reported health, or it could be an objective measure of health, such as can you walk for a certain number of minutes a day and so on. Whatever is the health measure. But the source of the inequality is income. for income-related health inequality measures. Right, so they're looking based on the distribution of income, what is the distribution of health. Our framework says that income is not the right way of looking at distribution of health, because income looks at effort. People can be differently educated. People can take up different kinds of opportunities, like real work opportunities, because of which they have differences in income. So looking at any factor which is an effort and then correlating it with health does not tell you anything about the sources which come from things which are not in their control, right? So if because of your geographic location where you're born, if that is what is leading to lack of access, if because of your race or your ethnicity, that is what is leading to lack of access, then that is incorrect. And if you find that a lot of the inequality is because of these kinds of sources, which are circumstances, then that is not right. And that needs to be fixed. So it's a different framework. It's just a different way of asking the question. Instead of looking at the source as income, we're looking at the sources of inequality as the circumstances. Okay. So there are a few other questions which I will take. So there is a question from SP Gore. Any comment on minority status? So minority status, it's still a very small proportion in China, but still they do exist. So they are these which are communities. So the predominant community is the Han Chinese. And then you have a lot of other minority communities. And they have some special let's call them privileges or benefits. For instance, while there are now reforms in terms of the one-child policy, but for the minority communities, the one-child policy was never applied. They were always exempted from it. For instance, they would always have larger families. They would live in certain parts of the country, so that would by itself limit their access to certain public services and so on. So they are still different from the majority, which is the Han Chinese. Although of course it's not like they're very remote and not integrated. No, that's not the case. But there were certain policies which never applied to the minority groups, which is why we control for that. There is a question by Suresh. How can you compare India's situation of health with China in accordance with issues of inequality of opportunity? So there are I think at least one or two papers, I don't remember, and is it Abhijit Singh or Abhishek Singh? I forget his first name. But essentially, he looks at inequality of opportunity based on caste. And what he finds in terms of outcomes, he looks at immunization rates in one of the papers. And I think there is also a paper that he's done on education outcomes. So he looks at caste as the main circumstance and finds that there are significant differences in health based on caste. So again, a very similar framework in terms of using caste as a circumstance. And then, the argument is the same, that circumstances, if they determine inequalities, that's wrong. That needs to be corrected either by policy intervention or in other ways. So there is a question, which minorities are considered, if any? What is the numerical composition of urban, rural, and migrant at a particular year at a national level? Now, that's a good question. In our sample, I can go back to the summary statistics, which is, I would say, fairly representative. I don't know whether you can see the scroll. I'm scrolling down the screen. If you cannot see that, please do point it out to me. So you will see that in this particular year, so 3,004, about 3,040. 8,700. So rural population is still a lot more than the urban population, nearly twice. And the migrant population is much less. So this is just a national survey, and we have weighted all our analysis accordingly, but this would be more or less the distribution, that numerically rural population would be more than the urban. The migrant population is increasing. The numbers keep changing they also do a mini census in China. I don't remember the precise numbers top of my head, But within these two waves, 2002 and 2013, the migrant population had nearly, I think, increased at least by like 50%. So that's a huge increase because of the internal movement within the country. So yes, hopefully these questions are addressed.
Yeah, I think we are past time. So thank you very much again, Namrata.
Thank you,
Uh,
Chirantan.
this brings to an end for 2020's Virtual Healthcare Research Seminar Series. This is the 25th one in the year. When we started in March, we didn't anticipate we will come this far. So thank you for your support and everyone's support who have joined us. And please feel free to reach out to Prof. Namrata over her email if you have other questions. Thank
Thank
you,
you,
everyone.
Chirantan, once again, and thank you everyone for joining in. Thank you.
Stay safe and take good care, everyone. Bye-bye.
Bye. Bye.